We're very happy to welcome Catherine Paradis, who is Technical Officer now on Alcohol, Illicit Drugs and Prison Health Unit. She works on the Special Initiative on NCDs and Innovation at WHO Regional Office for Europe. Thank you, Catherine.
Thank you. Thank you. Can you hear me? Yes. Okay. Thank you. Good morning, everyone. So I'm Catherine Paradis. I'm a technical officer at WHO Europe. And so while my current role mandates me to take a look at Europe and the 53 member states in Europe, today is an exception, and I'll speak about Canada and work I conducted there prior to joining the organization a little bit over a year ago. So I'm going to be presenting Canada's guidance on alcohol and health, work that was done under the auspices of the Canadian Centre on Substance Use and Addiction, a project which I co-chaired in collaboration with 26 experts from across the country. All right, so Canada's first low-risk drinking guidelines. In fact, the first one came out in 2011. And at the time when the first guidelines came out, about almost 15 years ago, the recommendations were for women, no more than 10 drinks per week, no more than 2 per day. And for men at the time, it was no more than 15 per week and no more than 3 per day. There are no clear criteria on when guidelines should be updated, but it was around 2019 that Health Canada, our Ministry of Health, and experts in Canada started to feel that there was time. There had been, in fact, significant developments in the knowledge about alcohol-related death and disease. There was evolving research on alcohol and social harms, particularly violence, sexual violence, and other countries had recently updated their guidelines, France, UK, Australia, and they all had come up with numbers that were significantly lower than the ones we had in 2011. So for all these reasons, in July 2020, it was decided that it was time to update, and funding was confirmed to move ahead with that project. So how did we go about that? So there were 3 research questions that guided this project's evidence collection, analysis, and conclusions. The first one was, what are the long-term risks and benefits associated with alcohol use? The second one was, what are the short-term risks and benefits associated with alcohol use? And what are the effects of alcohol consumption by women who are pregnant or breastfeeding? So from the outset of this project, there was common understanding among the experts that to update the guidelines, those 3 specific research questions would be answered through mathematical modeling. That is, by estimating the lifetime risk of alcohol-related death and disability caused by alcohol. So modeling had previously been used in 2011 and more recently in Australia, in the UK, and as we just saw, also in France. So the tricky thing with modeling is that it requires alcohol mortality risk functions for each disease and injuries that can be related to alcohol use. And so where do you find those risk functions? You find them in meta-analysis that assess this dose-response relationship between alcohol use and a particular disease. And so what this means is that the quality of modeling depends upon the quality of those risk functions, of those meta-analyses that you have. So you really need to put efforts into identifying those high-quality meta-analyses. There is a titanic amount of systematic reviews that have been published over the years on the association between alcohol use and health. But thankfully for us, in 2020, when we started this work, the Australians, who had just updated their guidelines a few years before us, had used the same methodology and had already covered the 2000 to 2017 period. So for that period, we knew for each disease what was the best meta-analysis that was available. So that means that our team only had to cover the post-2017 period. I'm saying only the post-2017, but that still meant that there had been 6,000 systematic reviews that had been published since then on the relationship between alcohol use and disease. Our team appraised every single one of those 6,000 studies, and we did so using renowned instruments such as GRADE and AMSTAR. And so for each one was assessed, which means that ultimately, for each disease, each conditions, we were able to identify the absolute best systematic review, meta-analysis, that would give us that risk function that we needed. So, of course, in the media, and some people following the release of the guidelines tend to say, these people claim that they use 6,000 studies. It's not true, they only use 16. Well, the fact that we only had 16 had nothing to do with us being biased, but everything to do with the quality of the methodology that we used. And a few more words about those 16. I'm saying 16 studies that we used ultimately, when in fact there are 20 conditions that we know are caused by alcohol. So why did we get 16 and not 20? It's because, for example, for cancer and for some cardiovascular disease, the same, it was in the same meta-analysis that those conditions were covered. I should also say that those 16 studies, in fact, those 16 meta-analyses covered 368 studies, 10 million participants, more than 500,000 cases, and you can, the results of that work has been published, and you can scan the code over there. So, equipped with those studies, we were able to pass the baton to our epidemiologist, who in this case was Kevin Shield, and ask them to develop risk curves estimating the relationship between average alcohol use and years of life lost. And we asked him to identify 3 different points or threshold on the risk curves that would represent 3 different levels of risk. We asked him to identify the average alcohol intake associated with a protective health effect. We asked him to identify where there would be the 1 in 1,000 cut point and the 1 in 100 cut point. And Pierre has already talked about this, but I'm going to repeat it because sometimes it's not too clear. So why did we ask about the 1 in 1,000 and a 1 in 100? Well, throughout our life course, we know that there are established thresholds of mortality risk that people are willing to ask. And so, as Pierre mentioned, for things we don't control, like the quality of air, the quality of water, vaccines, society is willing to accept the risk of 1 in 1,000,000. For behaviors that we can control, smoking, unprotected sex, jumping from a plane with a parachute, for these things, society is willing to accept a greater risk of 1 in 1,000. For alcohol, we're willing to accept even more. For which reason? Cultural, who knows, but we're willing to accept 1 in 100. And so that's why we use those 3 cut points and ask which was the number of drinks associated with those. And this is what we found. For protective effect, we found 1 for 1 standard drink per week. The 1 in 1,000 cut point, we found this was associated with 2 standard drinks per week. And the risk of premature death of 1 in 100, that was associated with 6 standard drinks per week. Before reaching, and I should say that we found the exact same number for males and females, and I'll come back to that. So before reaching any conclusion, what were we going to do with those numbers? And so before reaching that, in parallel to the modeling, we also agreed to commission 3 additional reviews for which we wanted additional evidence. Indeed, there were topics like alcohol and violence, which could not be included in the modeling for methodological reasons. And there were other topics like alcohol and women for which we wanted more nuance and more qualitative information that would go beyond of the results of the modeling. We also did we commissioned Cochrane to do a systematic review on alcohol and mental health, which was another topic we were interested in. Moreover, throughout this whole project, there was a commitment to consider Canadians' views, preference, and expectations about alcohol guidelines to improve the strength of our updated recommendations. And so overall, based on systematic reviews and interviews that we did throughout the project with Canadians, it became very evident that regardless of the scientific qualities of the guidelines, to be credible, updated guidelines would need to meet people where they're at by providing them with actionable guidelines on alcohol. And the public consultation also revealed the importance of not only informing people about the existence of the guidelines, but also about the reasons for their existence. Without fully understanding the risks and benefits associated with alcohol use, people are very unlikely to understand why they should follow these guidelines. And also, 4 months before the release of the final report, we did a public consultation on our draft report. And that allowed us also to nuance our message, to make sure that it was well understood by people, and to refine our public communication around the final report. So, what were the results of those 2.5 years of work? So before I go into that, we've talked about this, but you need to know that in Canada, a standard drink is 13.45 grams of alcohol. So a little bit more than here in Belgium or in most in Europe, or in Australia, where it is 10 grams, or in the UK, where they don't even call it a standard drink, but a unit, and where it is 8 grams. So in Canada, 13.45. And so this is what we came up with. So firstly, with a view to meet people where they are at, the experts agreed that instead of providing people with strict rules and recommendations, people should be presented with a continuum of risk associated with various levels of alcohol use. So the information to be shared with people is that there is a clear continuum of risk, whereby the risk for those who consume 2 standard drinks or less per week is low. That would be a low risk. It is moderate for those who take between 3 and 6 standard drinks per week, and it is increasingly high for those who consume 7 standard drinks or more per week, with increasing risk conferred by every additional drink. Our hope at the time was really that a continuum of risk would allow people to situate themselves where they are on that continuum of risk and understand in which risk zone their alcohol use places them. It was hoped that this would lead people to develop intentions to adopt healthier behaviors, to move to the upper level of this continuum of risk, the greener side of it. And so it was also important for us to communicate that the subtext to this continuum of risk is that overall, every standard drink counts, and any reduction in alcohol use is beneficial. So this continuum of risk applies to everyone in the population, not just those that drink a little, but everyone. You're at 40 drinks per week and you're willing to decrease to 30, it's already an improvement. And let's move from there, but every reduction is beneficial. The expert, as I mentioned, we also looked at other types of evidence to support people who may wonder about the consequences of occasional drinking or immediate effects. And with that, we came to the recommendation that people should never take more than 2 drinks in one occasion to make sure that they do not increase the risk of harms to self and others, including injuries and violence. We also had a recommendation regarding reproductive health. And so when pregnant or trying to get pregnant, there is no known safe amount of alcohol used. And when breastfeeding, not drinking alcohol is the safest. I mentioned that when it comes to the modeling and the risk curves, we got the same numbers for males and females. However, we felt it was very important to note that at 7 or more standard drinks of alcohol a week, the health risk increased more steeply for females and for males. But also, we felt important to note that far more injuries, violence, and deaths result from men's alcohol use, especially in the case of per-occasion drinking. So men should not get a free ride over here when it comes to this guidance. And also, of course, we had some recommendations for alcohol and youth, reminding them that drinking is a leading cause of deaths and social issues among them, and that youth under the legal drinking age of 18 in Canada should delay drinking for as long as possible. So overall, I mean, we came with this general recommendation that you need to reduce. To reduce the risk of harm from alcohol, it is recommended that people living in Canada should consider reducing their alcohol use. There were, of course, some implication to this report. And I mean, it was not lost on us that our updated results, which put forward this continuum of risk, was surprising and unsettling to large segments of the population. But however, fundamental idea underlying this project was that people have a right to know. They have the right to know that overwhelming evidence confirms that when it comes to drinking alcohol, less consumption means less risk of harm from alcohol. Alcohol is a carcinogen related to at least 7 types of cancer, including common ones like breast cancer. And furthermore, in contrast to common perceptions that are very prevalent in Canada, drinking a little alcohol is not good for your heart. It is a risk factor for most types of cardiovascular disease. Alcohol is frequently associated with injuries, with accidents, as well with violent and aggressive behaviors, including intimate partner violence, male to female sexual violence, and aggression and violence between adults. So this project has really confirmed that less is better. And from this fact, it is necessary to promote the message that, you know what, it is okay also to not drink alcohol. And if people choose not to drink, that is just fine. I have to say that when we updated Canada's low-risk drinking guideline project, we anticipated that the new guidelines would set lower limits of alcohol use. What was not anticipated, though, was that the evidence would reveal the extent to which even a little alcohol, very small amounts of alcohol, can be harmful to people's health and well-being. And that was a surprise to everyone that was involved in the project. Finally, the guidance was also intended to contribute to evidence base for future alcohol policy, to make wise decisions about such good. About alcohol, people need encouragement. And a corollary to the current project is a requirement for governments to design a healthier environment that will help people, and that's a sentence I keep repeating, that will help people make difficult decisions about alcohol a little bit easier. So as a priority for people to adhere to the guidance on alcohol and health, we know that consumers need consistent, easy-to-use information on alcohol containers to accurately track the number of drinks that they are using. And so one of our recommendations is that there should be information about the number of standard drinks on the label of alcohol containers. Our public consultation also revealed that without understanding the risk associated with alcohol use, people are very unlikely to understand why they should follow the guidance, why they should aim to reduce their alcohol use. And so therefore, the requirement for standard drink labeling should be accompanied by a requirement to label all alcoholic beverages with health warning. This was the clear policy recommendation that came out of our report. And it was especially important to make it in the Canadian context, where Canada has been a world leader when it comes to labeling on tobacco packaging. It's now, it has made it mandatory to have it on all cannabis product that is now a legal commodity in Canada. So why not on alcohol? This is really an important element that the government needs to put into place, especially that our ministries of health second core responsibility is to assess, manage, and communicate the health and safety risk and benefits associated with all consumer goods. I think that that's pretty much the case for most governments, and so the duty to warn through those labels is really key over here. So I think that's it for me. Thank you very much, and yeah.
Thank you so much, Catherine, for your talk and for these revolutionary guidelines from Canada. We'll take 1 or 2 clarification questions, and then just to remind you, Caroline said it, we'll have time for further discussions in the roundtable with our 4 speakers from the morning. But if you have 1 or 2 clarification questions, we can take one. Yes, please. Can you introduce yourself, please?
Yeah, John Holmes from the University of Sheffield. Thanks, Catherine. That's really great. And it's nice to see that the Canadians have taken the advice that has been given by lots of people to have a continuum of risk in the guidelines. But I was interested to know, what do you actually put on product labels then? Because that diagram you showed with all the different levels is probably too complex to put in a readable form on a product label. So what do you put on them?
So we didn't do a full report on what would actually be on the label. We still think that having this slice, because this little continuum of risk now, this colorful one, is becoming more and more shared and presented. And I think that moving forward, just a pictogram of that, people would be reminded of what it is about. And, you know, just with the 2, the 6 on it, that could be possible. There were discussions that maybe it should be the low risk numbers that should be presented on the standard drink, not on the standard drink, on a label about the number of drinks. But yeah, it's a discussion that we've not fully had, and that, well, I'm no longer part of since I now crossed the ocean and came over here.
Thank you, Catherine. And maybe a last question. We had a question on the Q&A from someone participating online. You're talking about the continuum in colors, and the question is, would we need a Nutri-Score for alcohol use? I guess the parallel between the colors and the continuum.
I'm sorry, have what?
Could we have a Nutri-Score for alcohol? Do you know the Nutri-Score? It's the labeling for food from A to E. Green to, well, red.
I mean, it could be part of it. I think that if, I mean, labels, on an alcohol containers, there's just so much real estate that is available. Maybe in a priority, the warning label should be there. Number of standard drinks so that people can count. The Nutri-Code, yeah, maybe. That could be a possibility also, but I think we need to go by priority.
Thank you, Catherine. Maybe a last question. I saw Florence at the end. Can you introduce yourself, Florence, please?
Yes, of course. My name is Florence Bertoletti. I'm the Secretary General of the European Alcohol Policy Alliance, also known as Eurocare. Thank you so much for this fantabulous presentation. It was amazing. I was struck by one of the things you said, one of the slides, about people willingness or awareness of accepting a risk. And you said that it was 1 in 100 for alcohol. So my question is, you've talked about it at the end, but I think everyone, should think very carefully about how they communicate the research or the work that is done on the drinking guidelines. Because basically, what are the objectives? Are the objectives of the guidelines to ensure that people are aware of the risk or that people change their behavior? What I'm saying here is that it's 2 very different objectives. The first one is accepting a risk or taking a risk. And the fact is that with alcohol, people are not even aware that there is a risk. And so the objective of the communication of the research is fundamental. What do you think about this?
So, I mean, the guidance is not aimed to change behavior per se. It's to increase knowledge about alcohol, and hopefully this will lead to changes in behavior. I think for us, what was very important was, first of all, to convey this idea that any drink comes with risk, and that the more you drink, you know, the more your risk increases. The 1 in 100 versus the 1 in 1,000, and which one to choose, I should say, came out. This was a solution that came out of of the context. First of all, we did this work between 2020 and 2022. We were in the middle of a pandemic. And every day people were exposed to those sort of colorful graphs with level of risk, at least in Canada. You know, is today a day where you wear the mask or you don't? And so people had become accustomed to this type of communication. And we thought maybe there's something there. I should also say that I mentioned we were 26 experts around this project. So I've often joked that while this might not give me the Nobel Prize in medicine, I'm certainly a contender for the Nobel Peace Prize for sure. This was quite something. And we had several clinicians around the table who would argue with the more social science type of people, or even the epidemiologists. And they said, as a clinician, I cannot make recommendations that would people at a 1 in 100 risk of premature death. I would not do that for anything else. So it was over my dead body, or we're going to use that cut points. And then, but we had, you know, the social reality of it, which is if we come out with do not take more than 2 drinks per week, no one's going to listen to us. So this is how we came up with this continuum of risk, which, I mean, again, I've left the country now 15 months, but I still have a little bit my antennas over there, has led to a lot of very interesting conversation. And is less, people don't feel being patronized. It allows them, again, to situate themselves and maybe just to try to move a little bit on that continuum. Let's reduce by 2 drinks this week and see how I feel. You know, I don't feel so bad. Maybe I feel better, and continue. So I don't know if this answers your questions, but this was a bit of the thinking behind it, and I think I'm over time.